I specialize in pushing the limit. So perhaps that'll be the theme of the next two topics. I'm going to talk about DCES as well as LCI, invasive livedoor carcinoma, but the focus of it will be on data that I have to present regarding the use of target in the treatment of DCES. I'd like to start by thanking my research assistants that sort of do the work of providing data to me that, and also in supporting patient accrual to our trials. As some of you know, I'm a fairly nocturnal surgeon. I'm up late many nights, and they receive many emails from me at 2 or 3 o'clock in the morning asking for more data. So I appreciate the work. That happened last night as well. So I appreciate the work that they do to help me get talks together. And I also want to just acknowledge the fact that a lot of the work that I do is supported by a private foundation. So thanks to the patient and the donors for enabling me to employ research assistants to do the work that allows me to advance what we know about target and its various applications. Now, there's been a lot of talk about the use of target in the management of invasive cancer. Of course, all of us have been a part of those debates over the last decade. And now we're actually looking at the use of target in the treatment of DCES. You saw presentations yesterday that addressed that. But it acknowledges the fact that we have continued this sort of irony of being very hesitant to treat DCES in innovative ways, and having a double standard about the way that we manage DCES versus invasive breast cancer. That's reflected in the ASTRO guidelines, where we have this sort of very conservative subset of patients with DCES that we're allowing to treat, but we're much more liberal, if you will, in treating invasive breast cancer when DCES is a much less life-threatening condition. And as the NIH considers it, it's not even cancer. They think it's a sort of it's something that can develop into cancer, but many of us don't even consider DCES cancer. This is all happening at the same time that we're debating whether or not patients with DCES need any treatment at all. Maybe just tamoxifen or removal without radiotherapy. There are various treatments that can be done, and they all are under investigation. But the key thing is that we need to be open-minded about how we manage patients, and we should be open to exploring the use of DCES, the use of target in the management of DCES. Now, this is one publication that sort of helped move us forward. It looked at the use of the mammocyte approach to management of DCES, and we see with APPI, this form of APPI, analysis of 300 patients from 2 pooled analysis showed a 2.6% recurrence rate, 2.6% recurrence rate at 57 months, which is very similar to what we saw in the target trial for invasive breast cancer. So it at least opens the door, again, to the use of APPI for the management of DCES. But we've been slow in generating data for IRT in the management of DCES, and I hope to share some of that with you in a moment. Now, we get some indirect indication that IRT, and particularly target, might work for DCES if we look at the Target A trial. It was a randomized trial of invasive cancer, but as you well know, most patients, or many patients with invasive cancer, have coexisting DCES. In the Target trial, 50% of patients in both arms had DCES as well as their invasive cancer, and yet you saw in the pre-pathology group equal recurrences, low rates, 2.1 versus 1.1%. The Target was able to control not only the potential for invasive cancer recurrence, but also the potential for DCES recurrence in these patients. So it's working. It didn't work only against the invasive component. So the challenge, I think, for DCES is not really a biological challenge. It responds to radiation, and it responds to partial breast radiation and target as well. But it's really an anatomical challenge. Can we identify patients that have limited enough disease that you can resect with clear margins, leaving a low burden of disease in the perimeter to allow you to offer that patient a very targeted dose of radiotherapy? So this is really a challenge. Finding patients that don't have this problem either macroscopically or microscopically, that can be a source of a recurrence. We also have some evidence that people are already using target to treat DCES. This is the Target retrospective publication. We mentioned it yesterday. It was publication of 800 patients receiving target predominantly for treatment of invasive cancer in the community setting, but there were 9% of patients in this study that had target for DCES alone. So it's clear that some of you are embracing it, but we need more data, we need more time, and I hope to share some of that, I plan to share some of that. A few years ago, I published this paper. It was mentioned yesterday. This is analysis of 35 patients treated with Target for DSAS, at which point he had a median follow-up. I can't exactly remember what it was, but I'm going to update it. But we had about a 5.7% recurrence rate in this group in a mixed population of both pre- and post-pathology patients. I didn't actually stratify it by pre- and post-pathology because there were too few patients to really go through the effort. But we'll do that in the update, and you'll see what that showed. But basically, it involved patients that were enrolled prospectively. Is a non-randomized single-arm analysis. It's something that I started at USC and have continued since as an interdepartmental protocol for treatment of patients with DSAS. All patients have biopsy-proven, core biopsy-proven DSAS, or histological confirmed DSAS. We enroll patients with DCS up to 4 centimeters in size by imaging, and all patients obviously had to be candidates for breast-conserving surgery. Patients underwent a single wire or bracketed wire localization. The majority of patients were treated in the pre-pathology setting, although when the study was initiated, we didn't have the information that post-pathology treatment was inferior. So we do have some patients in the analysis that were treated in the post-pathology setting, but most were treated in the pre-pathology setting. Sentinel biopsy was performed only if we suspected that the patient had an invasive component. All patients underwent intraoperative specimen x-rays, and the aim for surgery was to resect DSAS with a 10 millimeter gross margin, but we allowed in the initial study design margins that were 2 millimeters or greater. So we considered a margin less than 2 millimeters to be a positive margin. That was ultimately changed, but that was the initial definition of a negative margin, less than 2 millimeters. And those patients that required re-excision because of a margin less than 2 millimeters underwent re-excision and whole breast radiotherapy. The primary endpoint of this study was the successful delivery of IRT, with the secondary endpoint being local recurrence. The reason for this is one of the questions is, can we offer Target and perform it with the low risk of re-excision in patients because of positive margins? And so we actually set that as our primary endpoint with local recurrence as a second endpoint. So the goal was to at least be able to offer targeted patients and achieve a re-excision rate of less than 15%. If we could do that, then it was worth the effort to offer patients Target at the time of the initial resection. This was done in a setting where we've seen publications of 20 to 40% re-excision rates for DSAS, so we didn't want to subject all patients, 20 to 40% of patients to radiation at its initial operation if they were going to be coming back for re-excision. So that's why we set a very low threshold for allowing re-excisions. Again, the secondary endpoint, which is the one you're most interested in, is a local recurrence rate. Patients were followed semi-annually for the first 3 years and then annually, and they had mammograms done at those time points and had MRIs performed as needed in the follow-up interval. So these are some of the results from the updated analysis, now of 54 patients. It was 35 in the initial analysis. As you see, most patients were postmenopausal, but a third of the patients were between 40 and 50 years of age. I've highlighted the imaging size. The maximum dimensions on mammography was up to 20 millimeters for about 70% of the patients, although some patients had larger lesions. Grade, most were actually high and intermediate grade, not low grade. Only 13% of the patients had low grade DSAS in this analysis. So I'd like to make the point that I didn't stratify the data by cautionary or unsuitable because I actually don't really adopt the ASTRO parameters for defining that. It's my bias in my analysis of this. And in fact, but if you look at the data, you'll see that patients were generally, had larger lesions that were higher grade than what would have been included in the suitable category based on the ASTRO guidelines. There was also about 22% of patients that had hormone receptor negative DSAS as well. In terms of the pathological size, this is based upon the surgical pathology results. We see that majority of patients had tumors, DSAS measuring up to 3 centimeters. A few had lesions that were more in the final resection specimen. Negative margins were achieved in 91% of patients. And about 55% of patients, although most were hormone receptor positive, 55% of patients did not take endocrine therapy, tamoxifen therapy after their treatment, after the surgical resection in target. So this is the local recurrence rate that you're most interested in. There were 54 patients in this analysis. There were 4 recurrences amongst the 54 for a 7.4% recurrence rate when the recurrence rate was not stratified by time of treatment delivery, target delivery. However, when you stratify by the time of treatment delivery, there were 50 patients in the pre-pathology setting, 4 patients in the post-pathology setting, and when you look at the recurrence rate by timing of treatment, there was a 4%, 2 out of the 50 in the pre-pathology group that had recurrences. Obviously, that number of 50% of the patients in the post-pathology setting is a little bit high, but we only had 4 patients in that group, and 2 of them developed recurrences, and that gave it a 50% recurrence rate. But as again, we discontinued offering target in the post-pathology setting very early on and continued to offer it in the pre-pathology setting. And as a result of that, we achieved much more reasonable rates of recurrence, 4%, with a median follow-up of 45 months for the pre-pathology setting. There were no regional recurrences, no distant recurrences. And just to have a few comments about the patients that recurred, as I mentioned, there were 2 patients in the post-pathology group that had recurrences. 2 of the 4 patients in the post-pathology group had recurrences, and one was a 49-year-old that had delayed IRT after initially undergoing lumpectomy for DCIS. She underwent target in 27. She underwent re-excision and target about 151 days after initial lumpectomy, and that patient ultimately recurred. She actually, when she underwent target and re-excision, she had margins that were inadequate, less than 1 millimeter. She had a high-grade lesion. She was a 49-year-old woman. We recommended whole breast radiotherapy. After re-excision, she did not decline re-excision. She declined whole breast radiotherapy. 12 months later, she presented with new mammographic findings that yielded a diagnosis of DCIS, and she underwent a mastectomy. So she declined the recommended therapy after the initial closer positive margin, and she recurred within 12 months of that. The second patient had a diagnosis of ADH on core biopsy. She underwent an excision and was found to have DCIS. She underwent a re-excision with target given at the time of the re-excision. She was found to have 4 centimeters of additional DCIS at the time of the re-excision. Was again advised to have re-excision, mastectomy, or at least radiotherapy. Declined those as well and recurred 6 months later. There were 2 patients in the concurrent group or the pre-pathology group that had recurrences. This is 2 of the 50 patients. The first patient was 58. She presented with an intracystic papillary carcinoma, underwent a concurrent target at the time of the resection of the papilloma, and recurred was 7 years later with invasive carcinoma in the same breast, same quadrant, underwent re-excision, or rather a partial mastectomy again, whole breast radiotherapy, followed by tamoxifen, so her breast was able to be conserved following her recurrence. And the last patient was someone who presented at the age of 47 with DCIS in the medial left breast. She had a history of Hodgkin's lymphoma, had mandatory radiotherapy. We offered her a target and a lumpectomy, which was successful initially with widely clear margins, but she presented, I can't remember the year, but it's 6 years later with a recurrence in the same breast, same quadrant, and underwent a mastectomy at that time. So in summary, we had a 4% recurrence rate. You can see that it lines up or compares reasonably well to other studies that looked at recurrences with DCIS with follow-up periods in the same range, 3 years to 4 years, up to 5 years. Clearly, it's still a small study, limited sample size, but it has longer follow-up than we previously reported and more patients. We certainly need to have more follow-up, but we'll share and publish the data that we currently have. But it does make the point that I think DCIS is a reasonable target, if you will, for target. Just a matter of patient selection. We've achieved, I think, excellent local control at 4 to 5 months in pre-pathology patients. But clearly, based upon our small sample size, it sort of confirms that post-pathology treatment is inferior. Next steps for the DCS group is that I would encourage you all to consider participating in the SWOG trial. Hopefully it will be approved. I think it's a great trial, great design, and it will allow us all to come on board and build the data that we need to promote the use of Target for DCS. For those that may not be able to participate in in SWOG, we'll also have a registry to Target that will enable that. And there's still some discussion that needs to be had about the margins, because I think the 3 millimeter margin requirement is too conservative. I don't have the data to share regarding that, but I think that will be challenged also by the data coming forward. Now, in the next few minutes, I'm going to present not a whole lot of data, but at least some sort of a perspective on the management of Target, management of invasive lobular carcinoma with the use of Target. I'll call it ILC, because otherwise my tongue gets tied. There we go. One of the sort of double standards we have again, or at least ironies, is that we tend to be much more conservative in our management of invasive lobular carcinoma, even though biologically it's no worse disease than invasive ductal carcinoma. It comes with some challenges, but it's not any worse. So as a result of what ends up being sort of an imaging problem primarily, we've pretty much eliminated the patients with invasive lobular carcinoma the option of receiving partial breast radiotherapy. And that was true for the Target trial as well. Those patients were excluded. In fact, if you look at the various guidelines, ILC is not included amongst those that are considered to be candidates for APBI. We excluded it in the Target A trial. It was excluded in the Target US Registry trial, which I discussed yesterday. It is included in the Target Boost trial, but then all of those patients also get whole breast radiotherapy. They're not allowed to receive IRT alone. Now, the underlying problem, though, is not really a biological one, but the issue of imaging is that, it's a challenge to find, suitable patients. I acknowledge that. With mammography and ultrasound, it often understages the extent of disease for patients with invasive lobular carcinoma. But not all ILC patients have large or extensive lesions. In fact, if you look at analysis, this is one of them that looked at a large number of patients presenting with invasive lobular carcinoma. Only 12% of them had those very large lesions that presented with architectural distortions that was just impossible to estimate, the extent of the disease. In fact, most patients had lesions that were under 3 centimeters in size. This actually sort of stratifies the patients by their mammographic appearance of the invasive lobular carcinoma. And you see that for the architectural types, which is the one that is highlighted, 77% of those patients had lesions that were more than 3 centimeters, which obviously would be a challenge for risk conservation in general. But all the others, there was only a minority of patients that had lesions that were over 3 centimeters. So at least raises the question, or opens the door to offering some of these patients a more targeted treatment, Target or other forms of APBI. When you look at the biological question, it's even clearer. Invasive lobular carcinomas are less aggressive than the invasive ductal components. This looks at the overall survival, ILC versus IDC. It's better for ILC than for IDC. So again, why are we treating these patients more aggressively, if you will? If you look at the local recurrence rate, ILC versus IDC, the same local recurrence rate. Why treat them differently? So, that's kind of, the backdrop, but the truth is that some of us do believe that we can offer selected patients with ILC, Target, or other forms of APBI. And we see that in the Mammocyte registry, about 10% of the patients actually did receive Mammocyte type treatment for ILC, a diagnosis of ILC. In the Target retrospective, about 3% of the patients received Target for ILC. So we are beginning to open the door. And we now have B39, which did include, and does include ILC as well. So the door is opening, but we need to be, I think we need to work together to generate more data for ILC treated with Target. And so I'm going to present to you just a snapshot of a few patients that I treated, just for some perspective, but again, through cooperation and of prospective registries, which we hope to bring forward, we'll be able to generate more data to support the use of a target for ILC. In my experience, we had, again, a Department of Protocol offering target to patients with tumors that were core biopsy-proven ILC, patients age 45 and older, clinically node negative, LVI negative, no EIC, and less than or equal to 3 centimeters by imaging. And again, all patients underwent traditional workup, including breast MRI, core biopsies, and multidisciplinary consultation. I'm going to just share with you 8 patients that underwent target for ILC. As you can see, most of the patients were over the age of 50. All of them were, in fact. And most patients had lesions that were under 3 centimeters. In fact, of the ones we presented, 7 out of 8 had lesions that were under 2 centimeters by imaging. Histologically, most of the lesions, all the lesions actually turned out to be under 3 centimeters in size histologically, so they were a well-selected group. But some of the patients did end up having to undergo mastectomy for positive margins. At the end of the day, we had no local recurrences amongst the 8 patients that were treated in the trial. And at least, and as I said, we had 2 patients that required, can't quite make that out, 3 patients that required whole breast radiotherapy based upon the margin analysis. But when you factor out, take into consideration the fact that 6 patients were treated with target alone without additional radiotherapy, it does make the point that in the selected way you can identify patients that can be treated, or at least it's hypothesis generating that you can offer a subset of patients target for a diagnosis of ILC and do so with a low risk of local recurrence. So I won't go through all of those slides because I've run out of time, but it's clear that more data are needed, as is longer follow-up. But the concept that IRC is just not a candidate for APPI or target, I think, is a flawed one. It's not supported by the biology of the disease. And we can select patients that have limited disease that are a candidate for it. I think we should be open to that, and we think we should continue to work together to generate data supporting the use of target in a broader subset of patients, including those with ILC.